Ischemic strokes have a time-sensitive treatment window. Because of this, the initial workup has to be streamlined. The algorithm I follow is: step 1, stabilize the patient. Stabilize first, always. This is the essence of emergency medicine. If someone is unstable, it means a potentially life or death scenario for that person. My job here is to identify the most immediate and important problems, establish a plan, execute that plan, reevaluate the situation, and go from there. Step 2, check the blood sugar. Hypoglycemia can mimic a stroke. Hypoglycemia can be life-threatening, but fortunately, it's very easy to check for and it's very easy to treat. So checking the blood glucose comes second. Finally, CT of the head. This is the initial streamlined workup if there is any concern for an ischemic or hemorrhagic stroke. Welcome everybody to Essential Medicine. My name is Dr. Kennedy Hersey, and I'm here to teach you how to make the diagnosis. In a given 12-hour shift, I'll see roughly 29 patients. Of those 29, let's say 3 of them are presenting with a headache. Most headaches that come to the emergency room are not true emergencies, but it is my responsibility not to miss any of the real ones. So what do I look for? Is there a standard diagnostic approach? Let me share with you the broad strokes that 4 years of medical school, more than 12,000 hours of specialized residency training, and more than 15,000 patient encounters have taught me. An abbreviated guide to making a diagnosis. Somebody comes to you with a medical problem. Time is a constant, so start there. Is it an old problem? A new one? Attempt to identify the symptoms. Get some context. What was going on when it started? Were they watching TV, going for a run, hit by a car? You get the idea. Next, try to group symptoms to specific areas of the body. Finally, group things into systems. These systems in this case are pathophysiologic processes. For example, vascular issues, infection, musculoskeletal problems, rheumatologic issues, and then the specific organs themselves. Now create a differential diagnosis. This part requires a broad knowledge bank, and unfortunately, this is the part that requires medical school. The United States Medical Licensing Exam, Step 1, is a very difficult, very long exam that all medical students must pass in order to be allowed to practice medicine. It has a large emphasis on pathophysiology for this very reason, so that when the time comes, we can generate and work through these differential diagnoses. After all, solving a problem is always easier if you can identify it. Strokes are an example of a vascular event localized to the brain. Vascular issues tend to be the most emergent and thankfully rare. Actor-comedian John Ritter passed away suddenly from a ruptured AAA. Legendary sports commissioner David Stern, actor Luke Perry, both passed away suddenly from bleeding in the brain. During that shift, 2 of the headache patients felt better after treatment and had workups reassuring against an emergent cause to their headaches. The 56-year-old gentleman, we ultimately discovered that he had a small hemorrhagic stroke in the thalamus. We got his blood pressure under control, and his headache improved following analgesia. The rest of his workup was significant for newly diagnosed uncontrolled diabetes. I spoke to the neurosurgeon on call, who did not recommend operative intervention, so the patient was ultimately admitted to the internal medicine service with neurology on consult. Years of uncontrolled high blood pressure likely led to the hemorrhagic stroke. The internal medicine team quarterbacked his in-hospital care, optimizing his blood pressure, blood glucose, and lipids, while appreciating the neurologist's recommendations regarding the stroke. The patient had his first sessions with the occupational therapist to help him figure out how to complete his ADLs with his new neurologic deficits. The physical therapist worked him through his first session with exercises to help him regain function in his affected arm and leg. The social worker got him a wheelchair, arranged the first few visits from his home health aide, and they will follow up with him in about a week. After a 4-day hospital stay, the patient was discharged home. Unfortunately, this gentleman worked sporadically, currently working as a furniture salesman. He has no health insurance, no savings, and will be unable to pay for his 4-day hospital stay or his follow-up care. But that's a story for another day. Circling back to our patient when he first arrived, we find out that he was at work around 1 p.m. when the symptoms developed suddenly while he was sitting at his desk. He denies any fall or inciting event. Despite him having extremity symptoms, we're suspicious that the origin of his problems is likely above the neck. Anatomically, the only part of the body that impacts the arms and legs would be the head, spinal cord, and aorta. He denied chest pain, back pain, or neck pain, lowering our suspicion for aortic dissection. In the absence of trauma, few things cause acute spinal cord issues. Focusing on his head, the different groups of pathophysiologic processes include vascular, infectious, traumatic, rheumatologic, and others. Vascular issues can include a blocked blood vessel, a torn blood vessel, or a burst blood vessel. We have a lower suspicion for an infectious process given that he had no fever, no rash, no neck pain, or otherwise signs of meningitis or encephalitis. And finally, his symptomatology is consistent with a stroke. So now the main diagnostic question is this an ischemic or hemorrhagic event? Because their treatments are completely different and detrimental to one another. And there you have it, ladies and gentlemen. This is the end of the video. Thank you for making it the whole way through. Thank you for making it the whole way through. I appreciate you. A couple things I wanted to clear up in the video. One is about the USMLE Step 1. I mentioned that it is difficult, I mentioned that it is a difficult exam, but really passing and failing, to pass the exam is difficult, but what made it much more challenging was the implications of your score. So the residency that you wanted to do, the more competitive the residency, the higher the score you needed. And at this point, you're competing against other medical students that have had incredible GPAs, incredible extracurricular activities, very hardworking, and some of the most intelligent people I've ever met. So what really made Step 1 challenging was competing to get a high score amongst my peers. Now that they're moving to a pass-fail system, it changes a little bit, but Step 1 was a very rough time in my life, and I'm sure all other doctors and medical students can understand. Otherwise, I'm going to be trying to make videos every month. I'm going to be playing around with the different formats, the different styles over the course of the next few months to see kind of what you guys like and to also develop a style. So bear with me, hit the subscribe button to follow along. I hope you like the video. Hit that like button, it makes a difference with the algorithm, and I will hopefully be seeing all of you in the next month. Peace and love, and I'm out.